Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a totally unedited recording of Phaco emulsification of a routine cataract. The ocular surface is thoroughly irrigated with BSS or ringer lactate after instilling few drops of povidone iodine 5%. You can see that this is a cataract with nuclear sclerosis of about grade 3 or even softer, maybe grade 2 or grade 2 plus. This is how you place the main incision. A vertical groove, and then go to the floor of the groove, go forward for some distance, and then go downward and enter into the anterior chamber. One side port you can make at around 8 o'clock. Another side port you can make at around 2 o'clock. The main incision is at around 11 o'clock. So 3 clock hours away from the main incision, 2 side ports have been made. A big air bubble is injected to fill up the anterior chamber, and then trypan blue dye is applied over the anterior capsule. If it is applied underneath an air bubble, staining is faster, staining is quicker. And now many doctors don't wash the dye out, but this is a routine step for me. I always wash the dye out of the anterior chamber using BSS or ringer lactate. And now the anterior chamber is filled up with viscoelastic substance, and in this case this is 2% hydroxypropyl methyl cellulose. In India, this is a very economic viscoelastic substance. 1 vial of 5 ml visco costs only $2, maybe even less. And now Capsulorhexis is to be done. I am using a bent needle, a cystitome, to do that. Incise, pull, and make the flap, flip the flap. So the undersurface of the flap is now facing the corneal endothelium. And now guide the flap. First half, push the flap. You're pushing the flap at a certain distance away from the margin of the pupil, and from this point you are pulling the flap. So 180-degree push, and then turn, and then pull, and complete the rhexis. Once the rhexis is done, next step is hydrodissection. Use BSS or ringer lactate. Remove the capsular tag, and now go under the anterior capsular rim. You can lift the anterior capsular rim little bit and inject little bit of fluid. The fluid wave should go towards the opposite equator, and it should stop immediately. You can inject fluid on the other side. You can inject at multiple points, tap the nucleus several times. And now keep injecting BSS or ringer lactate and rotate the nucleus. Keep injecting fluid, then the antechamber will be nicely maintained. And now fill up the anterior chamber with visco. And now you are going to sculpt and make groups on the lens mass This is called the divide and conquer technique of Phaco emulsification. Your aim is to make two groups, one group perpendicular to the other group, and thus you make a plus sign. Go into the antechamber with bevel down, aspirate some lens matter so that you have better visibility. During sculpting, your setting is, your vacuum is 60 or 80, your flow rate is 20 ml per minute, and your ultrasonic power is 60% in this case. If the cataract is harder, you can increase the ultrasonic energy to 70% or even 80%. But this is a soft cataract. 50 to 60% ultrasonic energy is okay. You don't need much of vacuum. There is lot of air bubbles. Remove the air bubbles using only irrigation and aspiration. Don't come near the corneal endothelium. Remain at a safe distance. Use irrigation and aspiration and remove all the air bubbles. Now rotate the nucleus. No, before that you deepen the groove. Always go deep at the central part and not so deep at the periphery. Always remember the contour of the posterior capsule. Now this is another sculpting, another groove made 90° away from the original groove. Again the original groove is deepened. Again some air bubble somehow comes in. Be patient, remove the air bubbles and start again. In this case, the initial groove is not right through the center, so one heminucleus has become bigger than the other one. When it happens, you may not be able to divide the smaller heminucleus into two pieces. It doesn't matter, even if you divide the nucleus into three pieces, you can easily manage the case. So the groove is deepened, and at this time you can see faint red glow at the center, and now I try to divide the nucleus. Go to the floor of the groove and then apply opposite forces, and you can crack the nucleus into pieces. Yes, three pieces, and this piece, this smaller heminucleus, could not be divided. I'm trying to sculpt it and it didn't happen. And now each nuclear piece is tilted and brought out of the bag in this way. And then emulsification is started from the apex. At this time, go to Phaco 2 mode, where the vacuum is around 300 and flow rate is 30. When you are an experienced surgeon, you can use higher vacuum, but initially use lower vacuum and take longer time for the surgery. Maintain the antechamber very nicely. That should be the primary aim of your surgery. Always maintain the anterior chamber. The antechamber depth, antechamber stability should be very good. And maintaining the antechamber, if you take little longer time, there is no harm. You are always far away from the corneal endothelium, and you are far away from the posterior capsule. Always emulsify at the central part. Bring all the pieces at the center, bring the epinucleus at the center and emulsify. Don't try to emulsify when the tip of the phaco needle is at the periphery. Now I am trying to tilt this heminucleus and it tumbled, and I am holding it on edge at the center. I could divide it into two pieces. You also can do this, but it may be difficult. If it is difficult, inject some visco and place it at the center, and then apply ultrasonic energy and vacuum to catch hold of the pieces. During emulsification of the last piece, again you can inject some visco. At this time, come back to Phaco 3 mode, where your vacuum is much lower, maybe about 150 vacuum and flow rate is 25 or so, and you can emulsify the last piece. And now for removal of the cortex, inject some visco, and this visco will come out slowly, and as you clean the cortex with Simcoe, the antechamber will be maintained for longer time because there is visco inside, and you can remove the cortex. Most of the cortex can be removed going through the main wound. Still there is some visco and the antechamber is nicely maintained. Once the antechamber tends to become shallow, go through the side port and immediately the antechamber becomes deep, and remove the cortex from the upper part, from the 12 o'clock, 11 o'clock and 10 o'clock. The sub-main incision cortex. In this way, the cortex is nicely removed. You can use bimanual gradually, but there is no harm if you use a Simcoe cannula, which you are familiar with because you have done many small incision cataract surgeries using Simcoe. And gradually you can go to bimanual irrigation aspiration. And now fill up the antechamber with visco. Enlarge the main wound a little bit. The main wound was 2.8 millimeter. Make it about 3 millimeter. Make on cut when you go forward. Engage the edge of the keratom, and as you go forward, cut, and be sure that the antechamber is deep. The tip of the keratom should not touch the posterior capsule. And now inject the lens. The lens goes, the trailing leading haptic should go into the bag, and the trailing haptic may go into the bag. If it doesn't go, you can always dial going through the side port and place it in the bag. Once the lens is placed in the bag, your main part of the surgery is over, and now a very important step is to remove all the visco. Be very thorough in removing the viscoelastic substance that you have used, whether it is chondroitin sulfate or sodium hyaluronate or this 2% methyl cellulose, hydroxypropyl methyl cellulose, whatever it is. Be very meticulous, be very thorough in removing the viscoelastic substance. Otherwise, this viscoelastic substance will cause raised intraocular pressure in the postoperative period. The patient may even have pain in the night. The patient may complain next day, I could not sleep well. So always remove the visco very nicely. After removing some visco with Simcoe cannula, I use the irrigating probe, irrigate for some time, irrigate the anterior chamber, and then push the nucleus and go behind the nucleus and irrigate the. Now I take the irrigation aspiration both and use irrigation and aspiration together. I irrigate the capsular bag very nicely, and this is important because lot of visco may remain between the posterior capsule and the lens. So you have to irrigate the capsular bag going behind the intraocular lens. Now irrigation and aspiration is used together. And now you are sure that most of the viscoelastic substance has been removed. This is a bit of moxifloxacin. Now the side ports are closed. BSS is injected into corneal stroma on either side of the side ports. The stroma becomes thick and the stab wounds get closed. And now this is the final lavage of the anterior chamber. The anterior chamber is nicely formed. In this way. And now the integrity of all the wounds are checked using a cotton taped Johnson bar. There should not be any leakage from any side. And then the case is concluded. This is a totally unedited recording. Thank you very much for your attention. Hope this video will help you in doing your first few surgeries. Phaco emulsification by divide and conquer technique. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.